Welcome to AETCM, the emergency medicine channel. Today let us discuss about typhoid or enteric fever. It's a gram-negative infection, mainly affecting our stomach and produces diarrhea, fever and lot of complications. We'll see all these things afterwards. The organism is Salmonella typhi or Salmonella paratyphi A, B or C. The two important organisms, typhi or paratyphi. They are all gram-negative rod-shaped flagellated bacteria. Transmission is mainly through fecal-oral route. That is very important because patients who had typhoid in the past, through the feces, this organism, spores of this organism may enter to the water and it contaminates the drinking water. If we take this water or we cook food in this contaminated water, if not properly cooked, this bacteria can enter to the patient's stomach. From there, it multiplies and it enters to our body. So, gallbladder is one of the important organ in our body that produces this carrier state. So, this can remain in the gallbladder for many months or years. From there it can produce infection to other person through feces. It contaminates the water and infects other persons. The incubation period is around 2 weeks. So this bacteria, when we take food or water which is not properly cooked and contaminated, this bacteria enters to our lymph node tissue in the intestine. So that is very important. Peyer's patch is a type of lymphoid tissue in our intestine, and they enter there and they grow there, or that means multiply there. Then they go to the blood or they produces ulcers inside the intestine and produces perforation. So all these things occurs if we don't treat the patient properly. So one of the most important complication of typhoid fever in the past was perforation. So nowadays we are not seeing so much perforations because these patients are treated well in early stages itself. Now we already know that this bacteria enters to our lymphatic node, lymphatic tissue in the intestine. There they multiply or grow, then enters to the blood and produces all systemic manifestation of typhoid. Sometimes there in the stomach or intestine they produces ulcers, bleeding or perforation. That is one of the most important surgical complication of typhoid. Okay. Now chronic carrier state is explained in many typhoid patients. Nowadays it is less because of effective antibiotic therapy, but even then inadequate treatment or suboptimal management of typhoid still can have a chronic carrier state. These patients can have, or these carriers, healthy carriers can have bacteria in their gallbladder. Through the gallbladder it will go to the intestine and through the feces this bacteria or spores of this bacteria enters to normal drinking water, that they contaminate the drinking water. And when we use that water for cooking purpose, if not cooked properly or if not boiled properly, these bacteria can again enter to some other person's intestine and produces typhoid there. So that is very important. Decontamination in water, that is very important. Only by cooking properly or boiling the water we can achieve this target. Now, the most important clinical finding in typhoid is a type of fever that is called as step ladder fever. It is something like that. Step ladder means typically it will not be like what you are seeing in the picture. So, normally in any fever, the fever will be almost like, you take an example of a dengue fever or leptospirosis. Dengue fever, everyday patient will have high degree fever, but after 2-3 days slowly it comes down. Whereas in malaria, every 3 days or 4 days patient will have high degree fever, chills, rigors. In leptospirosis, initially patient can have high degree fever. Within 1 or 2 days, patient the fever subsides. But here, the patient will have one day a minimal temperature will be, second day it will be higher than the previous day, third day it will be again higher than the previous day, fourth day it will be higher than the previous day, like that it increases. But nowadays we are not seeing this type of charts because patient takes paracetamol. Whenever patient get a fever, patient take paracetamol. So most of the patients admitted in hospital, they can have only mild type of fever. Even then, the degree of the fever, every time when there is a spike, the spike can be very high nowadays. Okay, so that is because the fever pattern is altered because of the paracetamol. Whatever it is, the classical finding in Enteric fever is step ladder type of fever. That is very important. Step ladder type of fever, or everyday patient's fever is increasing. The intensity of fever is increasing. Now, other than that, patient can have headache, weakness, sweating, diarrhea, vomiting. This diarrhea is very classical in paratyphi infection. When we compare with typhi, they can have a little bit gastric irritation, mild diarrhea will be there. But paratyphi, the one of the most prominent feature will be severe diarrhea. Abdominal pain can be there. In second week, patient can have perforation, so that can produce severe abdominal pain. The symptoms of typhi and paratyphi infections are slightly different, and typhi symptoms are more severe than paratyphi infection. Paratyphi will have more milder symptoms, but the diarrhea part will be more in paratyphi infection. So that is main difference between typhoid and paratyphoid infections. Now there are a lot of skin rashes can occur in typhoid. They are called as rose spots, slightly raised red rose color spots which fade on pressure. That is very important, which is located mainly on the trunk, mostly seen in the trunk area, mostly on the back of the patient. But in darker colored patients, dark skin patients, these spots cannot be visible. That's why in our clinical practice we are not seeing this type of rashes very commonly, but a fair skin patient we can easily see all these things. Hepatosplenomegaly is very common in this infection. Most of the infections we get hepatosplenomegaly, but here also we get hepatosplenomegaly. Another important problem in this is not a problem, it's a finding. You see in Enteric fever and some other fevers like dengue fever also we can get it. Relative bradycardia. Normally, when we are treating a patient with high degree fever, there will be a typical rise of heartbeats according to your temperature. So every 1 degree rise in temperature, the pulse increases by 10 beats. But if that expected range is not there, then you can call it as relative bradycardia. Remember, this is not bradycardia, this is a relative bradycardia. That means you expect a temperature and you expect a heartbeat, heart rate for a temperature that is not seen. That is why it is called as relative bradycardia. It is not bradycardia at all. This is otherwise called as Paget sign. So relative bradycardia is one of the important findings of Enteric fever, but it is not seen not only in Enteric fever. There are other conditions also you can get relative bradycardia. Now, nervous system, many patients, if we don't treat the patient properly, they can have central nervous system complication like this called as coma vigil or muttering delirium or nervous fever. The patient can have altered sensorium with a type of abnormal movement. They try to pick up the bedclothes or imaginary objects. That is very important. That is mainly because of inadequate treatment. So some patients can have some peculiar type of face. Nowadays we are not seeing, they can see the patient's face here. This is called as typhoid face. So that is also seen in some patients, but this coma vigil can be there in some patients who are not receiving proper or adequate treatment. Now, one of the most important and dangerous complication of typhoid which is not treated properly on after the second week, third week, you can see the perforation. What you are seeing here is gas under the diaphragm. So that is very important finding of perforation. Normally you can see here whenever you have a like you can see here diaphragm will be there, both side diaphragm will be there. Left side you are seeing gas under diaphragm, that is because stomach is there. But right side you never see gas under diaphragm, this will be a diaphragm, there is no gas here. But what you are seeing here is there is a thin layer of gas here. So gas under diaphragm is a typical feature of perforation. In enteric fever, this occurs in the third week of the infection if not treated properly. This is the one condition where you get tachycardia in typhoid. Normally you don't get tachycardia in typhoid, you get relative bradycardia. But this is the one condition, this is one condition where you get tachycardia in typhoid. So patient develops peritonitis, perforation, all these things, patient can have tachycardia. Now, other complication, almost all organs in our body can be involved in this type of infections. We know that patient can have carditis, hepatitis, meningitis, nephritis, pneumonia, orchitis, arthritis, osteomyelitis, pneumonia. All these complications can occur in some patients. 1 to 5% patient can become chronic carriers even after complete therapy. Relapse occurs very commonly. 10% of the patients recurrent infection is possible. That is also because of chronic carrier state. Some patients will be healthy carriers. Chronic carriers can sometimes healthy. Sometimes they develop the disease. Now this picture tells you how typhoid spreads. It's a fecal-oral contamination. Then it grows in the Peyer's patch, then enters to the bloodstream. From there it produces all complication in our body. In Peyer's patch, when it grows, it can even produce ulcers, bleeding, rupture, perforation, all these things. Peritonitis is also common. Now, how do you investigate typhoid? Whenever we treat a patient with fever, the most important investigation we all do is WBC count. WBC count. So remember, this is a bacteria. This is the only one of the one of the bacteria which produces leukopenia when there is a bacterial infection. Normally, you take any other bacterial infection. Most of the bacterial infection, when there is an infection, you can see WBC counts are elevated. That is a classical finding of bacterial infection. But this is one condition where WBC counts are normal or low in a bacterial infection. Even in leptospirosis, you see similar picture. Even leptospirosis also you can get normal WBC count, or sometimes it can be low. But here you can see normal blood count or even neutropenia can occur in this type of patients. So that is very important. But remember, peritonitis again increases the count, like we discussed in the pulse rate. Relative bradycardia will disappear and patient develops tachycardia there. Here also WBC count can increase. So if you are seeing treating a patient who is having enteric fever and suddenly the counts are going, you are seeing there is a rise in the count, then remember patient might have developed peritonitis. SGOT, STPT, most of the infections you can see it will be elevated in 100. That indicates a small liver injury. Proteinuria, most of the fever patients you can get proteinuria. Blood culture is one of the important investigation you can do in first week of infection. So first week 90% of the patients you can get blood culture positivity and 50% positivity in second week. So that is very important. Now bone marrow culture is definitely a very good investigation in typhoid. 90% positivity you can get, but it is not practical to do bone marrow culture in every patient. Third week you can go for stool culture, so 30 to 40% you can get. But the most effective way of investigating typhoid is the blood culture in the first week. That is very important. Now, Vidal test is an antibody mediated test. You can see there are two important titers you are going to get in Vidal test, that is H titer and O titer. Remember, H titer is very important for making a diagnosis of your like typhoid fever. Titer 1 in 160, that shows an active infection, or titer appears early and disappears early, and H titer appears late and disappears very late. So H titer can be positive in previous infection, some anamnestic reaction can occur, some other infection also H titer can be positive. So O titer is very important. Raising titer is more important than static titer. Suppose initially it is 1 in 60, 1 in 80, then after 3 days you are getting 1 in 160, third day you are getting 1 in 360, 380, then it is very important to make a diagnosis of typhoid. Fourfold rise in repeated test after 7 days is a classical finding from 140 to 160. That is a raising titer. So that is very important. So viral test can be done in second week only, because most of the antibody mediated tests will be positive after 7 days. That basic physiology you should know. Antibodies are formed in second week of infection. Initially you have to do either PCR or you can go for the normal blood culture testing. Now ELISA test is again IgM antibody mediated test that can be done in even second week of the infection, not in the first week of the infection. Now, how do you treat typhoid? Because normally when we see a patient with typhoid, you can examine the patient from clinical examination itself. You may get a clue. Blood culture takes at least 48 hours. Clinical findings are high degree fever. Patient can have clotted tongue. Patient can have relative bradycardia. Abdominal pain can be there. Some diarrhea can be there. If it is paratyphoid infection, severe diarrhea can be there. That is a clinical diagnosis. Mostly typhoid is a clinical diagnosis because it takes another 48 hours to get the blood culture. Even viral also takes some time to get the report. So initially itself we have to start antibiotic. If you are suspecting a bacterial infection, you have to start antibiotic. One of the problem we face in emergency room will be the counts of this patient. WBC counts will be normal. So this condition mimics many viral fevers. So we have to take a chance and we have to give antibiotic in this type of patients. Clinically, you have to make a diagnosis of enteric fever. So you can give a antibiotic which can cover the gram-negative infection. Normally, doctors give ciprofloxacin 500 milligram BD. So that is enough in most of the infections. But remember, many time after getting a blood culture, you can see quinolone resistance is very common in typhoid. So that may be resistant. You can give ciprofloxacin or ofloxacin in initial treatment of typhoid. But if you are seeing a lot of blood culture with quinolone resistance in your area, you can even go for third generation cephalosporin. Normally we give injection ceftriaxone 2 to 3 grams IV OD for 10 days. Cefixime is a third generation oral antibiotic, and that also can be tried if the patient is not ready to take injection or patient is fully stable. You can give cefixime also. Ceftriaxone or cefotaxime also have similar finding. Chloramphenicol is a very old antibiotic. Nowadays we are not using because of bone marrow suppression problem. That also can be tried. But nowadays we are seeing even ceftriaxone resistant typhoid, then you have to go for piperacillin tazobactam or meropenem. That depends on your culture report. But initially only ceftriaxone or cefotaxime will be enough. If the patient is having CNS involvement in typhoid or altered behavior in typhoid, you have to give dexamethasone, a single dose of 3 milligram per kg body weight, followed by 8 dose of 1 milligram per kg given every 6th hourly. That is a very high dose, but in enteric fever with enteric encephalopathy, you have to give high dose of dexamethasone. This is a one steroid which crosses the blood-brain barrier easily. That's why we select dexamethasone in most of the CNS involvement. So prevention, improve sanitization, avoid contamination of water, or boil it properly, or like food should be prepared in clean hands. Patient can have the chefs can have typhoid free certificate. All these things should be practiced in community. So carriers, that is very important. Those who having typhoid, and if they are in food preparation industry, they have to get a certificate after checking their stools that they are not chronic carriers. If they are chronic carriers, we have to give ciprofloxacin or amoxicillin for 6 weeks. That also should be followed. There are vaccines available for typhoid. Different types of vaccines are available. I am not going to the details of vaccine. Everything is given here. This also can prevent infection, especially those who are taking food from outside home. So, and they are exposed to contaminated water source. So they can also take this vaccine that can prevent typhoid in our community. So we have discussed about one of the important fever condition, that is like it is occurring through fecal-oral route, contamination of water source by this bacteria, that is typhoid. Typhoid normally present with high degree fever. Every day the intensity of fever increases, then they can have like abdominal pain, some diarrhea, relative bradycardia. Coating of tongue is another important factor of typhoid. I didn't show the picture here. White coating of tongue. Some patients can have altered behavior. Some patients in second week or third week, they can have severe abdominal pain and perforation. That's a surgical emergency. So mostly these patients will have normal WBC count or slightly lower WBC count. This infection can mimic any viral fever. So we have to be very careful. High index of suspicion is required to make a diagnosis. You can treat this infection with normal antibiotics like ceftriaxone or cefotaxime or even quinolones. There are quinolone resistance reported in our country. A lot of patients are resistant to quinolone. So ceftriaxone will be a safe choice in typhoid. Thank you.